Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. Hello, Rational Wellness Podcasters. Today, the topic is H. pylori, the functional medicine enigma, with Dr. Vivian Abenaa Asamoah. I hope I pronounced that properly. Helicobacter pylori, H. pylori, it's a bacteria that lives in the stomach. How can a bacteria live in the stomach when it's all this hydrochloric acid? Well, it burrows into the mucosal lining. And at least 2/3 of the world's population has it in their bodies, though in the U.S., the level is much lower, maybe 25 or 30%, and maybe as low as 5% in young children. H. pylori can cause various GI symptoms, or it can be asymptomatic. Testing can include stool antigen test, PCR stool test, breath test, or blood antibody test. It's generally accepted in the gastroenterology world that if you find a patient that is positive for H. pylori, that they should be treated. In 1983, Dr. Barry Marshall proved that H. pylori can cause ulcers. And if you hadn't heard about his story, you should read about it, because in order to prove this, he really had to drink the solution of H. pylori, give himself an ulcer, take triple antibiotic therapy, cure himself, and then the ulcer was gone, and he scoped himself. And so for this, he won a Nobel Peace Prize. H. pylori can cause ulcers in the stomach and duodenum, and it can increase the risk of stomach cancer. But it also helps the immune system mature in children, and it may reduce the risk of hay fever, food allergies, asthma, and inflammatory bowel disease like Crohn's. It's also protective against reflux, Barrett's esophagus, and esophageal cancer. Dr. Martin Blaser, in his book, Missing Microbes, makes the case that we are better off with H. pylori than without it, and suggests that we should consider taking a probiotic containing various strains of H. pylori. Dr. Stephen Sandberg Lewis, who I've interviewed on the podcast 4 times now, who is a integrative GI expert, says that unless the patient has gastritis or the symptoms of an ulcer or stomach cancer, then we probably would be better off not testing for H. pylori and therefore not treating it. To help sort things out, we have Dr. Vivian Asamoah, who is a board-certified gastroenterologist. She emphasizes evidence-based, integrative, and functional medicine, combining integrative and conventional care. She went to the University of Geneva Medical School and did a residency and fellowship in gastroenterology, hepatology, and nutrition at Johns Hopkins. Dr. Asamoah, thank you so much for joining us.
Thanks for having me on, Ben. Thank you so much.
I'm surprised you can get a fellowship that includes nutrition from Johns Hopkins. Now, how much nutrition did they really talk about?
Not a lot.
Oh,
and
okay.
I'm one of those fellows who did a lot more nutrition rotations and worked with the obesity group. So I was always very interested.
There we go. So let's talk about H. pylori. Is H. pylori a friend or a foe?
I think H. pylori, that's a great question, Ben. I think H. pylori is a sneaky bugger. It's definitely it's a sneaky bugger because it can metamorphose into many different shapes, right? It's a helical rod, which has flagella, right? 8 flagella. So it can latch onto the epithelium and sort of like bury its way into that gastric mucosa. And under unfavorable conditions, it can also form into a sort of like cocoon. We call it the coccoid form, and hide away and hide itself and almost be undetectable, right? But there are also many strains of H. pylori, which is what I think we don't realize. And there are two strains that are definitely associated with badness in the stomach. That's the VAC-A and the CAG-A strains that are the virulent strains. But there are lots of other strains that are non-virulent. And another important thing is that multiple strains can coexist in the same person.
Okay, so can you explain what these virulence factors are? Because so those of us in the functional medicine world who are doing, say, GI map stool test, see that there's a report on how much H. pylori is there, and then they have a listing of these virulence factors.
Absolutely.
So do each virulence factor denote a different strain, or is this something besides being a strain?
It's besides a strain, it's something that's expressed. It's a protein that's expressed that can result in high oxidative stress in the body.
So it's kind of like an endotoxin.
Exactly. Release a low-grade, endotoxin, LPS, that's permanently there, and increase the risk. That virulence increases the risk of developing either peptic ulcer disease, gastric cancer, multiple lymphoma. For those are the virulence, the 50% of the time when someone has gastric cancer or peptic ulcer disease, that H. pylori carries those virulent strains, the CAG-A and the VAC-A. Yeah. So that's important. But some of them are non-virulent and really perhaps are friends and not foe.
So it's too bad that some of these tests aren't telling us about the specific strains. Maybe that's something that'll be coming down the road.
Possibly. But one thing that's also important to know is that these strains usually are, when they're present, they usually correlate with some kind of symptom or disease, right? There's active disease. So you want to look for a strain, of course, I feel, when someone has symptoms, right? Someone has symptoms, you want to go looking, because if you find it in an asymptomatic patient, then that begs the question, what are we looking for? And what does this actually mean? So
but are there good strains and bad strains?
There are potentially good and bad strains. I think there are strains that are protective because we know that there are certain strains. They even say that some H. pylori strains are actually protective against things like asthma, developing asthma, help us build our immune system as kids, and even protective against some forms of cancer like esophageal cancer and Barrett's esophagus, right? But then some strains actually increase our risk of the common things we've talked about, peptic ulcer disease, gastric cancer, but also may potentially increase our risk of pancreatic cancer and colon cancer. But I just don't think we know enough to really distinguish and really have, a clear sense of which strains are doing what and how the microbiome interacts with, the rest of the other bacteria interact with each other when it comes to H. pylori, right? Yeah, I think we need a lot more data. We need a lot more information, but it's a very interesting bacteria.
Now, a lot of people in the functional medicine world are giving their patients a GI map stool test, and this is one of the stool tests that reports on H. pylori, and not only does it tell you whether it's high or low, but it gives you a number. And so some feel that anything above detectable levels may be significant.
Yeah, and I, there are comprehensive stool tests are helpful for many reasons, right? We see how I think it's important to kind of know what's in there, right?
The microbiome.
What's the microbiome?
Pathogens.
Absolutely. And H. pylori does play a role in there as well, right? It plays a significant role, but it is a complex organism, right? And so I think that the issue we run into, and I think even the team from GMAPS will say, whenever you ask them, should I treat or not treat? Their answer is always, it depends. Always, every time I call for a consult and I ask, they say it depends. It depends on so many things, Ben. It depends on the host. It depends on the host immune system. It depends on the environment. What else is in that microbiome? Are we seeing there's complete dysbiosis and everything is off? What are the strains virulent? And what is the quantity? Sometimes they'll say, well, it's in the red, but it's not that high and they're not virulent strains. So do nothing. Maybe this is dysbiosis. And you could call a different consultant and they give you the complete opposite information. So you always wonder. And so sometimes the question is not always, should we just get all that information? But what do we do with the information, right? What do we really, really do with it? Because like Dr. Lewis says, he says, leave it alone. Only test for it if our patient has symptoms, right? And in gastroenterology today, we always say, well, if you're going to test for it because a patient has symptoms, you got to treat it. So when you find it and you're not sure how to interpret it on a GI MAPS test, because the PCR stool test is definitely not specific or sensitive to detect an active H. pylori infection. I think that has to be made clear to everyone, because in my experience, Ben, what I have seen is some overly aggressive practitioners treating our patients with antibiotics, and these patients for H. pylori, and these patients subsequently developing C. diff infection because they got antibiotics they didn't need, and then coming to me for FMT. Now, I may want to do FMT anyway, right? Because I think it's going to help, but we could have avoided that if we just left that guy alone.
Right. So disrupted the microbiome, affected the gut immune system.
Yeah.
By using broad spectrum antibiotics that the patient might not have needed.
Absolutely. And now the guidelines are very clear, and we can talk about that, Ben, whenever you're ready. The guidelines are very clear about what types of antibiotics we can actually use to target H. pylori, because we've seen so much resistance develop in the last 2 decades.
Now, let's just clarify for functional medicine practitioners who may be listening, who see H. pylori on a stool test and then decide to use a herbal regimen. Let's say to put the patient on mastic gum and oregano oil. What you're saying about the use of the antibiotics leading to C. diff is different than what you would say to the practitioners putting the patients on some herbal therapy.
Absolutely, completely different, of course. On herbal therapy, we're not going to see C. diff. But I think what I want to also share is that the presence of H. pylori on a PCR stool test is not indicative of an active H. pylori infection in the stomach. So if you really want
that alone is not enough. You need to do a second test to confirm it.
Absolutely. It can indicate that there's dysbiosis and there could be virulent strains. So we want to pay attention to that, right? But we know that children who even get virulent strains of H. pylori as children, if they have a strong immune system, they go through it. They move past it. They cure it. They don't need antimicrobials necessarily, even herbal antimicrobials. So you want to confirm, especially if your patient has symptoms, nausea, abdominal pain, early satiety, acid reflux, bloating. You want to confirm that this is indeed an active infection by either doing a urea breath test, a stool antigen test, and the most expensive one would, of course, be an endoscopy with histology. But all of those have a sensitivity and specificity of greater than 92 to 95%. Okay. But if you look at the results, and we never look at microbes in isolation, we look at the full picture. What does the garden look like? We're looking at what do the commensals look like? It's an opportunistic bug. So what are the other opportunistics? Is there dysbiosis? And at that point, we're targeting not just H. pylori, but the full picture. We're trying to, as we say, weed, seed, and feed, right? The whole picture.
Right.
Yeah.
Do you like the concept of the 4R or 5R program in general as a way to approach microbiome restoration?
I do. Do you?
I do.
I do. It works.
I'm an early Jeffrey Bland symposium goer for like 30 years, and I got the 4R program drilled into my head.
You have it down. You've had it down for many, many years. But new in the integrative GI space, I see that it works, and it works consistently if done right. Absolutely.
So does H. pylori increase or decrease stomach acid?
That's a great question. That's a really good question. So when H. pylori thrives under acidic environments, okay? And that's why we treat it when we're actually giving the antibiotic regimen, we always add the acid blocker medication, the PPI, because suppressing the acid formation will kind of put it into an environment that it doesn't like. It'll actually go into that coccoid form, right? But it does thrive in acidic environments. That's why the person who's going to get the H. pylori ulcer is the person taking an NSAID, a non-steroidal anti-inflammatory that's going to drive acid up. That's going to make the H. pylori just have a field day and thrive in that environment. So it does, and that's how ulcers are formed. So it does thrive, and that's why we use the PPI. So you don't necessarily want to be giving HCl in someone who has an active H. pylori infection.
This is not what's often said in the functional medicine world.
Mm-hmm.
And I think it has to do with which part of the stomach the H. pylori is present in. Mm-hmm. But it's generally told in the functional medicine world that H. pylori is a hydrochloric acid suppressor.
Mm-hmm.
Rather than something that increases hydrochloric acid.
So there are almost two phases, right?
Okay.
When you are initially infected and there's a lot of stomach acid, it can thrive in that acidic environment. As it becomes chronic and over time, it goes into a dormant phase, right? It will cause that chronic atrophic gastritis, which has lower stomach acid, right? So it's almost like a phase that it replicates in.
Oh, absolutely. Interesting.
Yeah, but the phase that we can knock it out in is when there's less stomach acid, right? When we suppress it. We know that when we add those acid blocker medications for 14 days and we suppress it, it reduces the replicative phase. It goes into that cocoon coccoid phase, and we're able to. And the antibiotics are a lot more efficient in that non-acid milieu.
Now, it is able to survive in the stomach by burrowing into the mucosal lining in the mucus layer. Okay.
Mm-hmm. Yes.
Recently had a discussion with Dr. Mark Pimentel from Cedars, and he's working on a new form of rifaximin, which is combined with a timed release N-acetylcysteine, because that breaks up the mucus. And when I talked to him about using NAC that's available now over the counter, he said, well, most of that would get used up in the stomach, helping to break down the mucus layer there. So I can't help but wonder, adding NAC to a H. pylori regimen where you've got a bacteria that's in the mucus layer would potentially be something that could be helpful.
That's my secret sauce. You got it. That's exactly what I do.
Is that right?
Pre-treatment, that's my secret sauce. So pre-treatment of my patients before antibiotics or even before antimicrobial herbals, if I decide not to go the antibiotic route, I treat with NAC.
Or why not do it with it at the same time?
I usually will start with one. Antibiotics can be quite harsh on a patient, so they're already struggling with taking, if it's quadruple therapy, it ends up being 56 pills with the bismuth.
Okay.
That's a ton.
Okay.
So I usually will pre-treat them for about 2 weeks and then start the antibiotics. And there are studies that have shown that there's a potentiating effect. It breaks up, it is a mucolytic, so it works a lot better. It scatters the organisms, and the antibiotics and the antimicrobials can target them and really reach and eradicate, right? And so there's also studies actually, and that's my second secret sauce is probiotic use.
Okay.
While giving antibiotics. Now, this has not made it into the American Gastro Association guidelines, but there are quite a few studies that have shown that addition of probiotics while having your patient on antibiotics potentiates and potentially improves the eradication rates post-treatment. So,
are there particular strains of probiotics that are more beneficial.
Bifidio and lactobacilli reuteri. So certain specific strains have been shown, but it's usually a combination of those commensals. Yeah.
And better with it than afterwards?
I don't know if there's studies that are looking at it during and after. The study that I know is during with antibiotics. Okay. So what I typically do is give it during the antibiotic course, which is always 14 days, and then I prolong it. I give it for an additional 30 days afterwards.
Sure. Okay. I've really been enjoying this discussion, but I just want to take a few minutes to tell you about a product that I'm very excited about. Imagine a device that can help you manage stress, improve your sleep, and boost your focus, all without any effort on your part. The Apollo wearable is designed to do just that. Created by neuroscientists and physicians, this innovative device uses gentle vibrations to activate your parasympathetic nervous system, helping you feel calmer, more focused, and better rested. Among the compelling reasons to use the Apollo wearable are that users experience a 40% reduction in stress and anxiety. Patients feel that they can sleep. Their sleep improves up to additional 30 minutes of sleep per night. It helps you to boost your focus and concentration. And it's scientifically backed. And the best part is you can get all these benefits with a special $40 discount by using the promo code Weitz, Weitz, my last name, at checkout to enjoy these savings. So go to Apollo Neuro and use the promo code Weitz today. And now back to our discussion. So when you suspect that there might be H. pylori, let's say you have a patient with gastritis or symptoms of ulcer, for example, what is your favorite go-to test?
The easiest one, I think, is the urea breath test. It's easy. It can be done in the office, or, the patient can go to any traditional lab and get it done it takes less than 20 minutes. Most important thing to tell the patient is stop the acid medication. So a PPI, don't take a PPI for 2 weeks. And this, again, is because the PPI will cause the H. pylori to go hide. It'll put it into that coxoid form. So you may not detect it. So maybe end up right, exactly. So we say make sure you have stopped your PPI for 2 weeks before doing the test. But that test is extremely sensitive and specific. Yeah.
Are there any foods or diets that affect H. pylori?
I'm not sure about foods, but what I have read, and there's a lot of data to support this, is that micronutrient deficiencies, right, will increase, that's sort of like a terrain to get H. pylori, right, especially vitamin D. So they're seeing that a deficiency in vitamin D increase in H. pylori incidence. This just goes to show how powerful vitamin D is in the immune system.
Yeah.
They didn't see it as much with vitamin C, which I expected as an antioxidant. They didn't see it as much as with vitamin C and vitamin E, but vitamin D deficiency, definitely. And the healthier your diet, meaning non-processed foods, wholesome, organic, plant-based, the lower the chance of you getting H. pylori as well. So that too has been shown.
Interesting.
Mm-hmm.
So let's talk about treatment.
Which kind?
Why don't we start with the evil sister, the pharmaceutical?
The pharmaceutical, the evil stepsister. Okay. So we got to talk about the evil stepsister, because the evil stepsister does work. Okay, it does work. And trust me, I have tried herbal therapies for months and months and months trying to eradicate. I have not been successful. But when we're talking about antibiotics, we have to look at the recent guidelines from the American Gastro Association. They've come up with these guidelines because more so now than ever, everyone's been on some form of antibiotics, as you know, Ben. Everyone's taken zithromycin and this and that for a little something they didn't need it for. And so the resistance level has just increased like substantially. So in a state like Texas, where we have people from all over the world, right? We've got people from Africa, like myself, from Ghana, where H. pylori is very, very common. People from South America, Latin America, we see that influx. And so the resistance profile for H. pylori is significant. Clarithromycin, we're seeing over 30% resistant rates. Metronidazole, same, very, very, some as even high as 50% resistance rates. We're seeing resistance as high as 15 to 20% with levofloxacin. So those are no longer first-line therapy. Not at all. That old school regimen of amoxicillin, clarithromycin, and a PPI, gone. First-line therapy right now is actually the quadruple therapy, which is amoxicillin, which has very low resistance rates, less than 1%, I hear. Very, very low. Tetracycline, very low resistance rates as well. A PPI, right, a proton pump inhibitor, and bismuth. And this is a hefty regimen because they have to take it 4 times a day. And as I said, 56 pills. It's usually not my first line. It's not my first line because most patients are calling me in the middle of the night like, Dr. V, I hate you. This is horrible. I am nauseous. My tummy hurts. I can't take this anymore. So I usually go to the what's the second line therapy, which is amoxicillin. So amoxicillin is a staple here. So unless the patient has a penicillin allergy, we're seeing very low resistance, but we're using amoxicillin at a higher dose at 1 gram with rifampicin with a PPI. And what's new on the market now are these potassium competitive proton pump like PCABs, right? Vonazepam.
An alternative for acid reduction.
It's an alternative for acid reduction. Actually, it's a much more powerful acid reducing agent. It's been used in Asia for many, many years, just was approved, FDA approved in the States probably a year to a year and a half ago, but it does suppress acid for a lot longer, more than even 24 hours than the traditional PPIs. And using that in combination with amoxicillin and rifampicin and whatever other strategy, we're seeing better eradication rates, right? The treatment is always 14 days, nothing less than that. So that's the stepsister. Those are the recommendations there.
Okay.
Yeah.
And what percentage eradication rate do you get with that?
Oh, so it really varies, but anywhere between 85 and 88%. So it's not perfect even with that. Yeah. I think we've seen higher numbers with the PCABs in the 92, 93%.
And my understanding is that H. pylori can be transmitted through saliva or bodily fluids. So if a patient comes in with H. pylori, do you recommend testing their spouse or significant other or other people in their household?
Absolutely, 100%. This is another thing that changed in the guidelines. Before, the gastroenterologist would just be like, oh, no need to test. But that has changed in the guidelines. The recommendation is test the family, those living in close proximity in the home, test all of them. Now, when it comes to children, I think give kids a chance, right? Because if we start just doing antibiotics, I think 85% of kids would have had H. pylori at some point in their life, especially kids who are coming from different parts of the world, right? I hate that term, developed and non-developing. I hate that term, but just more exotic parts of the world, right? So that's why the pediatricians are reluctant to just testing kids and just treating them, because there are some protective benefits of this bacteria, right? And it helps develop immune system. But yes, I'd treat the adults, treat the spouse, treat the kids, treat the siblings.
Dogs get H. pylori?
Dogs get H. pylori, absolutely. Yes,
you got to test the dog too.
Yes. Dogs get H. pylori. Yeah. So yes, we do test.
How do you get your dog to take 56 pills a day?
Animals take a lot of medications. We have dogs on BPC peptides and all of that. I have a very good friend. She's a functional veterinarian, and we share a lot of ideas. She's giving them BPC, and they've been using that in the vet world for many, many years.
Oh, really? For orthopedic issues?
Exactly. Yeah. In horses, orthopedic issues. Absolutely.
Huh. Interesting.
Yeah. Yeah.
What's the status of BPC 157?
I mean, we have it in a sub-Q formulation. We also now have it in an oral formulation.
I thought it was made a class 1 medication by the FDA.
It may be.
But you can still prescribe it.
Oh, yes. We do prescribe it. Yeah. I mean, they're trustworthy peptide manufacturing companies that you can use.
thought they had essentially taken it off the market.
Not to my knowledge. I don't know.
Okay. All right.
Not to my knowledge. We can still.
Okay. So what are some of the natural treatments that you can provide for patients with H. pylori? And everybody talks about mastic gum as one of the parts of that.
Absolutely. I think doing the NAC before and maybe even during and for as long as you can is definitely beneficial. Adding probiotics, mastic gum.
And for NAC, are we talking about like 600 milligrams 3 times a day or something like that?
600 milligrams. I usually pair it with the antibiotics, and usually they're about 3 times a day. So 600 milligrams 3 times a day. If I can go higher, I would, just depending on what the patient can tolerate. A good quality probiotic. Look at the strains of Bifido and Lactobacilli. You can prolong that for 90 days if you want. We see how many of our patients have tummy issues after those antibiotics, right? And if you want to go for something natural, and I don't believe that we are at a place where I can comfortably say that herbal therapies will completely eradicate H. pylori if it's a true H. pylori infection, like by urea breath test or stool testing. Now, if it's dysbiosis that you're seeing on a GI maps, what you may just be doing is just seeding, weeding, and improving things in the microbiome generally. And this we would do for whatever opportunistic bacteria is there. But mastic gum for sure. And I use mastic gum even in just gastritis, non-infection related gastritis, maybe chemical induced, antibiotic induced, stress induced. So we use mastic gum quite a bit. Clove is one that has been shown to have pretty good results for H. pylori. Ginger is another one, pretty good results for H. pylori as well. So there's
Allicin.
Yeah. Pretty good results as well. So there's several of them out there that we can, and in combination, I think when you're trying to sort of clear out dysbiosis, combination therapy in terms of herbals, very, very helpful. But those are my go-tos.
Okay. And then once you put the patients on these antimicrobials, do you ever rotate them on a monthly basis or anything like that?
So if H. pylori is part of a dysbiotic picture, and usually it's not the only one, there are usually other pathogens or opportunistic involved.
Elevated strep and staph.
Yes, exactly. So I would usually treat for at least a good 2 to 3 months, right? On some low-grade, some antimicrobials, right? Yeah.
And after treatment, do you retest?
So if I have a positive urea breath test, for example, right? Definitely confirmed. I'm not just treating dysbiosis here. I'm actually treating an acute active H. pylori infection. It's very important to retest. Very, very important to retest because, again, this bacteria is a sneaky bugger and can go and hide. So we want to make sure it's being successfully eradicated. So you want to retest about 4 to 6 weeks after treatment, 4 weeks after antibiotics, and about 2 weeks after you've stopped the proton pump inhibitor. Mm-hmm.
Right. Okay. And is there anything you do after they're done with their treatment?
5-hour protocol all the way.
Okay.
I go back
you try to rebuild a microbiome.
Rebuild. Absolutely.
So what are some of your favorite strategies, products that you like to use?
So I love to go with a lot of natural products. So I do tell patients if they have no histamine issues, I love for them to use some colostrum, do some bone brothing, right?
Okay.
Go green, leafy greens as much as possible.
So what do you think about colostrum versus serum bovine immunoglobulins?
I think they're both very, very helpful. I do use both in practice. I lean more towards the colostrum for different reasons. Some of it could be financial. I don't know. I find the colostrum more affordable for patients. But I think both are very, very helpful. Both are part of that 5-hour protocol in rebuilding the immune gut system. Yeah.
Okay. And then what else?
Glutamine.
Okay.
I think there's a lot of data in terms of glutamine and leaky gut, so we can never go wrong there. A good quality glutamine at 5 grams 3 times a day. And I like to keep it on for about 4 to 6 weeks, really just to rebuild. Definitely using, you always have to make sure that micronutrients have been repleted, right? So I want to make sure vitamin D. I always notice when there's dysbiosis, there's mild pancreatic insufficiency. So I'm repleting with digestive enzymes at the time. Zinc carnosine is a big one for the GI tract, as you know, Ben. So just making sure we're just following that 5-hour protocol and giving the gut enough time to reseal and heal.
Yeah, I often like to give the patient a micronutrient test as well to see where they're at in terms of micronutrients.
Very helpful. Very helpful. Yeah.
All right. Are there certain favorite products? Do you use combination products? Or you like individual glutamine, et cetera?
I do like individual glutamine just to get the dose in, because as a GI, functional person, I'm trying to always get the optimal doses. When patients come to me, they've already tried little things.
And there aren't that many products that have 5 grams. And if you're going to use some of those products 3 times a day, it's going to get more costly than just using glutamine.
Exactly. So I try and go for the pure glutamine forms, as much as possible. Yeah.
Great. Mm-hmm. So, what else do we want to talk about? Are there any other confusions you want to clear up about the integrative GI world?
Like what? No, I think H. pylori was a good topic.
Yeah, I think H. pylori is.
I think something that, patients always get very scared about is the risk of stomach cancer. Like, am I going to get a lymphoma, a gastric cancer? And the incidence, of a stomach cancer is relatively low. It's like 0.3%, which is
0.3%. Yeah.
0.3%, which is why I think Dr. Sandberg Lewis is saying, hey, it may not be a bad guy all the time, and treat only if you must treat if the patient has symptoms, because the chance that your patient is going to probably develop another kind of cancer from metabolic issues, imbalance, and insulin resistance is probably higher than targeting this H. pylori that's going to destroy their microbiome. So sometimes if I have a patient that's been treated 3, 4, 5 times with antibiotics, I leave them alone. I really just put them through the 5-hour protocol and I leave them alone, and I focus on what else is going on. What is the immune system telling us, right? Are there any other hits that we must focus on and figure out why your oxidative stress is so high, and how do we drive this down overall instead of just targeting H. pylori and hitting our head against a brick wall? And usually that helps a lot. We may see this bacteria regress on its own and disappear. So I think you kind of have to take every case, as we do in functional medicine, individualized, personalized, customized for the patient.
Great. Any final thoughts for our viewers and listeners?
It's been wonderful being on your show, Ben. I think this was a great topic. We don't hear a lot about it, but I really wanted to speak up on the stool PCR and everyone being careful, because I get the back end of it when patients come to see me and say, I've been overtreated. And so we want to be cautious. H. pylori is not always foe. It can sometimes be a friend.
What's kind of interesting is if a stool antigen test is considered a pretty valid way to verify that there's an active H. pylori infection, that would be an interesting thing for them to add to the test. So that way we got both of those positive, then we have a different perspective on it.
Absolutely. It's just that the PCR is overly sensitive and picking up just too many different strains that may not be significant, phenotypically significant.
Now, could an antigen test be added to a PCR test, or is that a whole different type of test?
I mean, I
don't see why not, right?
I don't see why not. It could just be an add-on.
Yeah, that would be interesting.
They do zonulin and a whole bunch of other things, right?
Exactly.
So why not? Yeah, absolutely.
That's great
idea. We should create our own test.
There you go. So how can listeners and viewers get in contact with you, find out more about you? Should they go to your website? Where should they go?
Yeah, so I'm on social media as Dr. Vivian Asamoah on Instagram, LinkedIn. We also have a private Facebook group called Natural Gut Relief, where we try and talk about everything integrative GI with in relation to gut health. You can find me in all of those places, and you are all welcome to connect if I can help in any way.
And what is your web address?
I don't have my web address, just my website. My website is Houston Gastro Institute. That's the website of the practice itself. Yes.
Okay.
Yeah.
Okay. And that's the best one to use.
Yes, that's the best one to use.
And do you consult with patients virtually?
I do consult with patients in the state of Texas and 12 other states now. We are credentialed and have malpractice in 12 other states. I work with about 3 dietitians, functionally trained. So we're a little team of health coaches and dietitians. And our focus is really chronic GI issues. So we see quite a bit of MCAS. We see a lot of IBD patients, complex IBD patients. We see a lot of CFO. We see a lot of SIBO. And that's EOE, those are our favorite patients.
All right, great. Thank you, Dr. Asamoah.
You're welcome. Thank you so much for having me on, Ben.
Thank you for making it all the way through this episode of the Rational Wellness Podcast. For those of you who enjoy listening to the Rational Wellness Podcast, I would very much appreciate it if you could go to Apple Podcasts or Spotify and give us a 5-star ratings and review. As you may know, I continue to accept a limited number of new patients per month for functional medicine. If you would like help overcoming a gut or other chronic health condition and want to prevent chronic problems and want to promote longevity, please call my Santa Monica Weitz Sports Chiropractic and Nutrition office at 310-395-3111, and we can set you up for a consultation for functional medicine. And I will talk to everybody next week.